A very good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And let's welcome today's speaker with great honor, none other than Dr. K. Suresh sir. And let me share some of the achievement of sir before starting this session. Sir has done MD, DIH, DF, DFIAP, FIPHA, FISCD, family physician, public health consultant, Bangalore and visiting professional practicing at KSRDRU, Karnataka. And today he will be talking on topic management of mobility in older adults, a comprehensive approach in smaller setting. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. You can proceed from here.
Thank you, Fayaz. Good evening, friends. Today, I will walk you through one of the commonest things which each general practitioner or
Sir, sorry to interrupt, sir. Little, sir, can you keep the mobile little away, sir? Little distance. Like your picture is getting cropped. Little distance, sir. Distance, sir. Distance. Perfect, perfect. Thank you. Just keep it.
Is it okay?
Yeah, yeah, you can proceed.
But voice might get interrupted, no? It's fine now?
Yes, sir. Fine, fine.
Hello? Good evening, friends. Today we are looking at the common issue of general practice today is people come to us with not just one single disease, particularly when we talk of chronic diseases, they have more than one. And therefore, as a practitioner, one needs to be careful in looking at primarily at the presenting complaint and then ultimately reaching what needs to be attended. So, therefore, this approach is called as multimorbidities integrated approach. As we know, chronic conditions starts almost in the middle age, around nowadays, even around 30, 40. Issues like hypertension, diabetes. Among women, it is arthritis, backache, menstrual problem, etc. Though anybody can have multimorbidity, it is more problematic among the elderly. In elderly, when we say we talk of people over the age of 60 years in India, but globally it is 65 years. Because this problem is across the globe, it all depends, as you know, what proportion of population is elderly. But in the developing countries, it poses a big public health challenge, not only for the government to organize services, but even as an individual doctor, we are likely to face the problem day in and day out. Older adults are at a greater risk of vulnerability due to their limitation in physical, mental, and functional health risks. When we say multimorbidity, it means a person having more than two or more of conditions. Generally, we say chronic. Sometimes it could be exacerbation of chronic or existing chronic, on top of it, some acute infection like COVID-19, dengue, or etc., etc. The multimorbidity is a complication based on the advancing age. Female gender are more likely to be suffering, and obese people. These are the determinants we call for the multimorbidity. With rapidly rising aging population and the increasing burden of non-communicable diseases and mental illnesses in the community, particularly depression, loneliness, the older adults, or what we call as elderly Indians, are at a greater risk of the multimorbidity. What is worsening is in the last decade, we see depression becoming highly prevalent among this elderly population, especially elderly people who are financially dependent on their children, sometimes even physical dependency, and of course, emotional dependency. A high prevalence of multimorbidity indicates high mortality and also increased health care utilization. It's common for the elderly people, the risk of hospitalization, disability, rehabilitation challenges, and even mortality. Sorry. Most importantly, multimorbidity affects the quality of the life of these elderly people. Of late, both in the Western world, what was common today, we also see that multimorbidity among the elderly is becoming a financial and social challenges for their children to manage. In the competitive world, they need to work hard, must be 10 to 12 hours, and then if the situation in the family is not good, they have to face challenge. Next. Guys, next. Next. Hello. Next.
Sir, it is next, sir. It is second slide. Burden of
Okay,
MMIE.
okay, thank you. Now we're looking at the burden now. The prevalence of morbidity increases, as I already told you, depending upon the age, which ranges from anywhere around 50% to 98% starting at the age of 60 years plus. A general understanding in India is it's around 50% among people under this age of 65 years, 62 to 65% in the age group of 65 to 74, and more than 80% among people who are age 85 or older. It is more common among women, as I already told you, than in men. In people who are literate or single, it does not actually mean that literate people are more sick, but they seek care. Our information is dependent on who seeks care, because the community surveys are very limited in the country. Therefore, it is a public health challenge, both for diagnosis, management, and outcome, particularly of CVD or cardiac patients. According to the Global Burden of Diseases estimates in 2021, the elderly population is going to increase about 5% per year for men and 4.2%, 4.2 years for women. That means every year the life expectancy increases around 4.9 years and 4.2 years among women. As a result of this elongated life expectancy, people will have to spend more years in poor health, suffering from CVDs, cancers, COPD, irritable bowel syndrome, constipation, cataract, deafness, etc., etc. Some common conditions include depression, anxiety, frailty, fragility, frequent falls, fractures, backache, arthritis, incontinence, and poor cognitive health. If you look at the diseases among these, is basically due to cardiovascular diseases, followed by COPD, that is chronic lung diseases, cardiorespiratory renal failure, hepatorenal failure. A community rural study in India has reported the multimorbidity due to the is around 59%, of which one third, that is 31%, had two conditions, 15.6% had three conditions, and 12% reported one, just two conditions. So if you have four conditions, that means you can look at that, nearly 50% of the population had more than two conditions at a time. And if you include single morbidity, the number goes to almost 70%. Even among those who did not report multimorbidity, as I told you, only 10% were normal clinically. And if you consider the biochemical markers or imaging, probably hardly 5% would be normal. What are the common conditions in Indian situation? We call it acid peptic, that is what generally is called a gastric problem, and musculoskeletal, either the backache, or joint pain, muscle pain, etc. That is the first priority, followed by these are what we call as a diads, and peptic disease, that is ulcers, IBS, musculoskeletal diseases, and hypertension. We call them as triads. That means three diseases at a time. And some more will be quadriad, where diabetes gets added. Among the non-communicable diseases, we see diabetes and hypertension is common in about 28% of the population. Diabetes, hypertension, chronic kidney disease is seen in another 8%, that is triple condition. Next. Further next. Okay. Now these diagrams gives you the regional distribution by gender of multimorbidity. You can see Asian countries, we are much less compared to Western world. Here the simple reason is, in the Western world, people live longer than Indian average. Number two, their diagnostic potentials are much higher than us. Our diagnostics are still limited mostly to clinical. Of late, in major cities, we do get some chemical biomarkers and imaging. Next. Faisal, next. We also see some gender differences in multimorbidity. Chronic heart disease, myocardial infarction, strokes, and congestive cardiac failures are much higher at the rate of 5.8% compared to women 4.6%. Chronic lung disease again is much higher at a rate of 9% among men as compared to 8% among women. Diabetes again, while 14.6 or 15% of men suffer, it is 1% less among women. But there are other conditions which are more among women than men. For example, hypertension is seen more among female, particularly obese female. It's around 37% as compared to 28% in men. The odds of diabetes were lower among the older adults living with spouse and children and other family members than people living alone. Similarly, the chronic lung diseases and chronic heart diseases were lower among female than males. In the multimorbidity criteria scale, heart failure, autoimmune diseases, dementia, and osteoarticular diseases are more frequent in women than men. While ischemic heart disease, chronic respiratory diseases, and neoplasms are predominantly seen in men. Next. Right. Now let us look at what is the current clinical practice in India. I make a first sentence says, approach to a patient nowadays depends upon the qualification of the service provider. In India, our basic medical education, irrespective of the system we learn, whether it is allopathy or any of the Indian system medicine, teaches us to look or approach a patient as a whole while giving due consideration to the presenting symptoms and also make a provisional diagnosis. If single diagnosis is not possible, we are always taught to make what we call a differential diagnosis, which may be confirmed by investigation if available. So that is our general practice. But what actually is happening in the last 2 decades at least, as I see, because I am in practice for 56 years now, with the advent of specialization and super specialists coming into the practice, we are becoming dependent more and more on investigations like biochemical markers and imaging techniques. So what do? They identify the pathology, either anatomical or functional, and doctors try to rectify them. The entire individual, except among the general practitioners, do not get attention from any of these specialists. So what happens? Now, this is leading to compromising the age-old practice of general practitioners who used to look at the patient comprehensively. Even now, some of the general practitioners do this. This is despite the fact we know the biomarkers and imaging techniques are supportive, but they cannot be the decision makers. As you can see, every report, there is a small note at the bottom which says corroborate laboratory values with clinical findings. That means these have to be used as supportive and not decisive things. Now, if we look at the current practices, generally practitioners, either the medical officers at the government health centers or a real general practitioner, which breed is coming very small now and maybe remaining still in rural India, particularly taluk and sub-taluk level, because districts and cities today are seeing specialists and super specialists. They are continuing to do, at least in the beginning stages of the patient's approach, and they use their own personal experience in the community they are serving for some time. Definitely, their interventions are not necessarily evidence-based, but they have seen the results, therefore they practice. Whereas if you come to urban India, the concept of family doctor is waning. Among my team of about 270 persons, elderly people who are in touch with me even today, I will show you a slide a little later. Most of these people living in state capitals and bigger cities complained that there are hardly any general practitioners in these areas. And even if they are there, they blame that they practice in urban poor or slum localities, and most of them are run by unqualified quacks. If we come to the super specialist and specialist in the urban areas, as I told you, specialists are there for nearly 3 decades now, as we have been seeing, and super specialist is a new breed in the last 1 decade. How do you define this? For me, a specialist is one who practices his or her practicing system. For example, a surgeon, a physician, an obstetrician or a gynecologist, pediatrician, otorhinolaryngologist, ophthalmologist. This means these people have studied something more in their systemic analysis, and at least that system they look at comprehensively. Coming to super specialists, my definition of super specialty is a person who knows almost everything about almost nothing. That is, such an extraordinary knowledge in a small area. So here, what they do is, they don't see a patient as an individual, but the affected part of their specialization only. Try to find out what is the fault and make an attempt to rectify, to make it functional on itself to the possible fullest potential. Sometimes it may be at the cost of some other organ in the body. And if you happen to go to the bigger institution, there will be multiple consultations, multiple prescriptions, and the doctor gets confused, or the patients get confused which one to follow. Next. Next. So now let us look at what pair of illnesses we see commonly. Go back. Now we call these combination of diseases dyads and triads. Dyads means two conditions simultaneously being there. Triad means there are at least 3 conditions. Now, as I told you, 60% of the elderly in India have at least 2 conditions. If out of these, if we further go into details, it is found that nearly 30% or 1/3 have 2 conditions, about 15 to 16% have 3 conditions, another 12% will have 4 conditions at a time, respectively. The common combinations, as I already told you, acid peptic disease, that means basically related to tummy upset, IBS, etc., and musculoskeletal diseases, which includes backache, joint pain, muscle pain, and in the respiratory system, it will be combination of bronchitis and COPD, asthma and COPD, with mild fever or what we call as exacerbation of all these conditions, any one of them. In the triad, apart from these acid peptic disease and musculoskeletal diseases, we see hypertension joins them. When it is fourth one, the diabetes is the one commonest which joins the road. Among the metabolic diseases, the commonest combination is diabetes and hypertension in about 1/3 of the elderly people coming to us. With this, either chronic kidney disease or liver disease becomes the third one in about 8 to 10% of the population. Or sometimes it's urinary problem, particularly in elderly men and women. Either it is difficulty to control micturition or bowel movement or constipation, and among men, it is benign hypertension of the prostate. The universal problem in 1/3 of the population today is depression, more prevalent among urban, single men, financially dependent men have more multimorbidity. Next. The most common clusters of morbidity in India, I have already talked to you. This is another listing where people come to you either with joint pain or hypertension, joint pain, muscle pain, and low visibility, basically due to cataract, diabetes and hypertension, frailty. Frailty is thin, only skin and bone person. Fragility is falling down or breaking any bone. And deafness, particularly partial deafness, has become common nowadays after the age of 65 years. The hearing problems also have sometimes sensitivity to a high-pitched sound. For example, people of my age, I'm around 80 now, if I'm driving a vehicle, if somebody horns from behind, I feel irritated. So there are these sensitivity, hypersensitivity to sound and or what we call as noise pollution. Balancing problems becomes common after the age of 70 years. Among women, cervical cancers, postmenopausal symptoms, cognitive health is becoming a common factor both among men and women. I am going to handle this cognitive health separately again, not getting into details now. Forgetfulness, depression, all these conditions put India at a 3 times higher mortality, 2 times higher disability adjusted life years, we say, compared to the global developed countries. Next. Next. There are other conditions which one must be aware of, which are basically exaggerating the chronic illnesses. This is where we come into the cognitive health. What do we understand by cognitive health? Is basically ability to think, learn, and remember clearly. This is a key part of the brain health and is important for performing our day-to-day activities. But as age advances, the impact on cognitive health is basically dependent upon genetic factors on which we don't have control, because some people are intelligent by genetics, some are average, some are loose.
Hello everyone. Due to some technical issue, the sir got disconnected. He will be joining us in any moment. I request all the participants, if you have any question related to this topic, you can put it in a comment box. Once sir join this talk show, he will take all the questions after the presentation. And I would like to thank all the participants who have joined this session. I once again request all the participants, if you have any question related to this topic, you can put it in a comment box. Once sir join this talk, he will take these questions one by one. As we know that this is a very important topic and sir is sharing the screen and discussing about this topic, as he is facing some technical issue and he will be joining us in any moment. I request all the participants who have joined this important session, if you have any question related to this topic, you can put it in a comment box. Once sir join this show, we will take these questions one by one. I once again request all the participants, if you have any question related to this topic, you can put it in a comment box. Once sir join this talk show, we'll take questions one by one. And as we know that this is a very important topic, and if you want to know more about this, you can just put your questions, doubts in a comment box. Once Dr. K. Suresh sir will join, he will take your questions one by one. As he is facing some technical issue, he got disconnected, and he will be joining us in any moment. I request once again all the participants, if you have any question related to this topic, you can put it in a comment box. Once sir join this show, we will take this question one by one. As we know that he is discussing one of the important topic. If you have any doubts related to this topic, you can put it in a comment box. Once sir join this show, we will take this question after the presentation, as he is facing some technical problem. And I would like to thank all the participants who took their important time to listen to this lecture.
Hello. Hello.
Yes, sir. You can proceed, sir. Thank you so much for joining once again, sir.
No,
You can
I'm
proceed, sir.
using dongle now. It's fine.
Yes, sir.
Sorry, dear friends.
Yes.
We
Yeah,
were
you
talking
can
of
keep the mobile
cognitive
phone
health.
little distance, sir. Sir, you can keep
Huh?
the mobile phone little distance from you, sir. The mobile phone.
Okay.
Yes, sir.
We
Perfect.
are now talking of one key condition which is becoming a problem. What happened again? We're talking of cognitive health. Basically, cognitive health becomes very important among the elderly for the simple reason, what is cognitive health? It's the ability to think, learn, and remember clearly. It's a key part of brain health and is very important for day-to-day functioning for everybody. This cognitive health gets impacted this because of there are a few factors. One is genetics, where we all know we get our intellectual capacities based on our parents and grandparents. Second, our lifestyle, for example, diet, exercise, and other lifestyle choices impact our cognitive health. And these can be modified. Third is an environmental factor like air and noise pollution, rising temperatures also impact our ability to think and act. Aging is one of the common, as we age, our cognitive functions start declining. The chronic health issues like hypertension, diabetes, asthma, irritable bowel syndrome diseases, and arthritis also impact the way we think and react. There are certain medications which we use for certain chronic diseases. Without our knowledge, they affect that. For example, stimulant drugs like nicotine or amphetamine improve our cognitive function at lower doses. But if the dose increases, the same may improve our memory, will impair our memory performance at higher doses. Similarly, depressant drugs like alcohol can cause long-term bad effects on prefrontal cortex function, disrupting cognitive abilities. There is an emerging diseases which we call as vascular cognitive impairment and dementia, which contributes to about 40% of about 5.5 million dementia patients in India. Traumatic injuries, as you know, people at this age fall down and get injured, even at home, not necessarily outside on the road. The only solution to keep these things little better is making your clients physically active by walking, gardening, housekeeping activities, doing any task which they did not do as youngsters. That means your brain has to do something more than what they can do reflexly. Next. The next three conditions, I am using some case studies which I have come across recently, and some of them I have managed, some hospitals have managed. First is a senior citizen coming from national capital Delhi to Bangalore, from a very hot climate to cold climate in Bangalore recently. A known patient of diabetes, hypertension, COPD, ankylosing spondylitis, benign prostate hypertrophy, and bilateral cataract surgery done, and left ear hearing problem since 4 years. He had an exacerbation of the COPD, went to a tertiary care hospital. As usual in any big hospital, physical examination is only for namesake. Then a battery of investigations were done. On day 2 and 3, he was asked to get second opinions from all possible specialists like pulmonologist for lung problem, cardiologist for cardiac problem, neurologist for his neurology problem, nephrologists, and each one of them gives their own prescription. And if you combine all of them, prescription which he came back to me as a practitioner, I could put them together and see there were 3 antibiotics, 2 antihypertensives, 3 oral antidiabetics, 2 anti-inflammatories, and cough syrup. In addition to that, vitamin D and B12 supplementation. He himself, being a medical doctor and in consultation with me because he happens to be my contemporary, we just decided that he would take what he was taking, except adding another antibiotic for exacerbated COPD, an antihistaminic and steam inhalation. Believe me, 3 to 4 days, he was normal in the sense what he used to be, not that all conditions improved. Similarly, a diabetic person from one of the towns known as Gangavati in Karnataka, who had to get amputated his left toe in April 2023, in June 2023, because of the blood sugar, and the local doctors found that the wound did not heal, so he amputated. Now, recently, again, he got his another toe in the right leg, middle toe here this time. Blood sugar level are marginally high at 150 mg per dl. HB1AC was also less than 7. Despite that, the local surgeon suspected it to be peripheral artery disease because he had seen earlier case also. Then the case was referred to Bangalore, where we consulted in August, and there the peripheral artery disease was ruled out, bone infection was ruled out. However, what clicked was a culture sensitivity test of the pus on the wound, which showed Pseudomonas aeruginosa, an appropriate antibiotic therapy for 8 days, and debating and dressing the wound over a period of 2 weeks healed the entire toe and saved the toe. Now here, where we say that what the laboratories can do for us, if there is an infection which is not amenable to routine antibiotics use, Pseudomonas aeruginosa infection is becoming common in Indian situation. I have been seeing this case at least every month, one such case. So please keep it in mind, a wound does not heal, irrespective of what the cause of the wound. If the routine antibiotics do not help them for a period of 8 to 10 days, get a culture sensitivity done and use appropriate antibiotic. The third case, now these are all 3 cases where people have survived from all mismanagement. Here is a lady of 72 years who consulted for toothache, a dentist who extracted this under the antibiotic cover and local anesthesia. After the extraction, wound did not heal for nearly a period of 4 weeks, which usually should do in about 3 to 5 days. A detailed examination of oral mucosa showed a discolored patch, and the dentist, again suspecting it to be oral lichen planus, made the palliative treatment, you all know, is aloe vera mouthwash, topical application of corticosteroid for 8 weeks. Imagine, for 8 weeks. When that also did not help, the family took the lady to a oromaxillary surgeon who did a biopsy, and it turned out to be cancerous. A surgery of partial mandibulectomy, removal of the tumor, and radiotherapy, she has recovered completely. Tumor, both primary and secondary, have disappeared, but her face is disfigured. She has become very frail because of the radiotherapy. Here, the lesson is, as a general practitioner, if any illness with your effort does not heal in a period of 8 to 10 days, please refer. Do not indulge for long. The patient suffers, in the turn, your practice will also suffer in future. Next. Now, there are some cases which result in death, similar mishandling of multimorbidities. A case of hepatorenal failure. Here, the person who had some liver, icterus, etc., had ascites. They were examined initially in Belgaum, and when they were back home in Chalakere in Chitradurga district, the ascites became heavy. They tapped first time and it refilled within 2 weeks. Next time they extracted lot of fluid, which resulted into protein imbalance. Kidney function start get affected. One fine day, the person started feeling giddy, breathing difficulty, and retention of urine. Admitted to a medical college, diagnosed as hepatorenal failure following hypoproteinemia, and person succumbed to renal failure. Another elderly gentleman of 84 years, a disciplined person, had an heart attack in 2022. In February 24, he reported to a private hospital with complaints of fever and cough, unusual bleeding from the gums, lethargy and fatigue. The routine CBC revealed that there are too many abnormal white cells, which we call as blast cells, indicating leukemia. He was under treatment for 6 months, showing improvements, but one fine day in July, he had respiratory distress, went to the hospital, and could not pull out beyond 24 hours, died on 21st August. So despite these multiple illness and specialist attention, the result was nothing encouraging. Another common condition, which most of you may face, what we call as renal pruritus. A lady aged 82 years in Sindhanur of Karnataka, bedridden for more than 2 years due to fractured femur. Bed sores were there. Her mobility was limited, and she was under a lot of stress because she was a widow. Her elder son had some family problem and many other family problems and dependency on the only younger son. Her health started deteriorating in January 2024, and sometimes in April they saw itching in the back. We thought it was more of a bed sore type developing. They tried the local Ayurvedic treatment, which involves eating bitter leaves, turmeric, and doing panchakarma. What they call panchakarma includes purgation, vomiting emesis, lepas, bloodletting. Of course, they did not do any bloodletting. She was also given what they call as Vardhinivati, but none of them helped. They consulted me on a video conference. Having seen the lady on the digital media, I prescribed simple oral antihistaminics, and both oral and for local application. To address her depression, we gave chlorpromazine 25 mg daily at night. topical application of, you have crotorana, which is a crotamine lotion. This helped her, relieved her within a period of week, but she had to continue long. The lady ultimately died of some other condition. Next. Now, this is a list of patients I have. There are totally about 271 patients. The age group is given, as you can see, out of 271, 85 are in the age group of 60 to 69, 131 in the 70 to 89 group, 79 group, and 80 plus are 55 people. Of these people, you can see in the last 1 year, almost 2/3 had at least one episode of multimorbidity. Among the 80 plus, it was almost 80%. So here, again, the common condition. If you look at the overall number, only 11 out of 171 had no clinical morbidity. I don't know if it was radiological or biochemical. So therefore, these are my clients spread across the country because most of these are telephonic communication. On the first column, you see the people who are grouped. The first one is what I call as RUC, is retired UNICEF colleagues. They are spread across the country. Then second is my 1962 MBBS batch students. That number is decreasing over the years. Third group is Alas, where I stay, apartment complex in Bangalore. Fourth is relatives and friends who contact me for second opinion, if not first. And finally, my regular patients. If you look at all of these, the multimorbidity is so common. Next. Next. Among these 271, those are women, we also lost 7 of our friends. The causes here are given. 2 of UNICEF colleagues died, one due to cardiac failure and another due to myocardial infarction. Our MBBS batch, 1 colleague died of cardiac arrest, and second due to secondaries of breast cancer. Our apartment complex, 1 person, I told you the case history of myeloid leukemia case. Another lady died by suicide due to poisoning. One of my relatives died of hepatorenal failure. Next. Next, please. So this makes me to infer that our clinical practice is at crossroad. Now I call this GPs are at HI versus MAI. Here I take an example of as a mother recognizes from her daughter or son's voice, even on a long distance call, whether the person is tired, feeling low or sick. I think we as family doctors or general practitioners do the same once the patient walks into our clinic. By his gait, his face, his eyes, his voice, and his accompaniments. If he's your regular client, you know already what the problem is. Now, patient's family's genetic disposition, family history of illnesses, help us, we as general practitioners, to put the patient's condition in a right perspective. Today, Globe talks of artificial intelligence coming into health practice also soon. What does it do? It is getting close enough to detect a range of diseases just by hearing a few seconds of a voice clip. Even breathing patterns shared on audio clip can diagnose respiratory, neurological, and mental health issues and autism. But let us remember, AI, that is artificial intelligence, depends upon what data you input. That means if there is no human intelligence or information fed into that, there is no artificial intelligence. All the claims today of AI are based on international expertise and experience. They may not apply to Indian population, particularly not to the local population at district or sub-district level. If AI takes over in clinical practice, should now what happens? There will be a competition between AI and human intelligence. Who will die? Now it's a question to see whether we should encourage AI, though it promises of equal intelligence or skill to all materialize. That means if you use this machine intelligence, a 40 years experienced person and a 4 months old practitioner become the same because you are using somebody else's knowledge and skills. Would that help? Second, operational issues will be, will these equipment be updated? If so, how often? As we already know, our own mobiles, etc., every week they come what they call as updates. So if that process is not done with the local data, big question mark comes in. So we say, therefore, generative intelligence is only human intelligence. That means only we can think and act, not an artificial intelligence. G represents generative, which is purely human quality. AI can imitate us, artists, authors, scientists, doctors, engineers, incapable of producing anything novel of its own. So let's be very cautious and don't be worried about the glamour of artificial intelligence. Next. Next, please. So in general, I say there is a disappearance of general practice in urban India for all the reasons I have quoted. They are becoming more and more AI oriented or equipment oriented intelligence. Next, please. Next. Faisal, next. So coming to what we need to do is, as general practitioner, we need to develop and follow certain things. Number one, communicating with older patient is a skill and challenge for general practitioner. Therefore, we must speak to the patient as a fellow adult, not depend on what their sons or daughter-in-laws come and tell you. Make them comfortable. Avoid hurrying. Don't hurry up like you are in a quick hurry. Speak in simple words. Avoid medical abbreviations. Words like MI, BPH, COX, BD, TDS, etc., etc. Address the patient face to face, write down or print out points for the patient and the attendants to follow, get ensured that instructions are understood with relevant feedback regarding the drug names, dose each time, how many times a day, before or after meal, etc., etc. Recognize that the patient coming to you are from different backgrounds, they have different expectations and intellectuality. Try to meet as many as possible for each patient. Next. So therefore, one another social responsibility I expect GPs to do is what I call discourage elderly people to pursue comfort. As age advances, people start aggressively pursuing for comfort. Oh, I am old, why should I do this? Fine, let me take rest. Whereas a youth is aggressively pursuing for experience and novelty. But that is the most riskier issue. Instead, we must see that our body, that is elder's body and our elderly patient's body and brain are put to more action. They will reward us. Promoting elderly clients to exercise their mind and body is very important. If for any reason they can't do both, you priority for physical exercise. Exercising the body is an ultimate to key to health, and fixing our diet adds value to it. You can promote cutting out refined sugars, cutting back on drinking habits if they have, stop smoking if they are smoking, eat more proteins either in vegetable or non-vegetable form, and cutting back on any inflammatory food like dairies and grains. Eat well, exercise, sleep well, and keep learning should be the motto once individual crosses the age of 60 years. If elderly stop pursuing comfort, start pursuing fulfillment, their life will improve. This downfall usually starts after the age of 15, not necessarily only 60. Therefore, one need to alert our patient right from the age of 50. There is a hope by starting exercising, exposing the brain to new challenges, and whatever they do, but do not seek comfort. Next. So currently, globally, we promote what is known as integrated multimorbidity care model, which takes into consideration, this picture indicates, an health system approach, which is to improve the access to the care, whether it is public or private, promote generalists, not the specialist, provide decision support involving the elderly person, their family members, etc., and a patient-centered treatment approach, which is building doctor-patient relationship, promoting shared decision-making and setting realistic goals, supporting patient and the attendant for self-management. Next. Next. So what are the elements of integrated multimorbidity care model? Basically, it takes 3D approach, dimension of health, depression, and drugs. The idea here is to improve their health-related quality of life. Is thus not an immediate treatment. The effective elements in patient-centered and multimodality care are approaches that are promoting self and family members in the management, because day to day you cannot take BP, you cannot take blood sugar for them. The family members need to be taught and see when to approach you. You need to support intervention and development of the training of healthcare providers or the family members for more frequent categories of illnesses and interventions, with the potentials to result in providing relief from presenting or exacerbated symptoms, and finally, a long-term positive impact for the patient with the chronic diseases. The basic modalities include a regular comprehensive review of the patient's problems according to their individual circumstances, a focus on quality of life and function as well as disease control, tailoring treatment to everyone's priorities and situation, and balancing risks and benefits of the treatment. Next. I was trying to go through some basics of these diseases, but since the time has been too long, I would cut short. You already know these cardiovascular diseases. Here, monitoring blood pressure in T position, looking for postural hypertension, and treatment not just by starting single drug, depending upon the accompanying complications, you may have to start 2 or 3 days at a time. Similarly, in diabetes, diagnosis based on fasting blood sugar and HbA1c, be alert of what is called as reactive hypoglycemia, monitor and maintain intra-day fluctuation, either hypo or hypo, and drug regimen based on associated diseases like cardiovascular, respiratory, etc. Chronic respiratory diseases. Next, please. I will quickly walk through here. Basically, I'm trying to put certain general information. The basic here in chronic respiratory disease is to look at the exacerbated symptoms, advise patient not to smoke or avoid second-hand smoking, maintain healthy body weight, healthy diet, be physically active, limit alcohol consumption, practice good respiratory and hand hygiene, get some recommended vaccination. There are nowadays vaccination for flu and all that, you know. And if there is a respiratory failure, mechanical ventilation, oxygen therapy, fluid therapy, managing underlying condition, and if required, referral for extracorporeal membrane oxygenation. Next. Musculoskeletal problems, basically it involves exercise, behavioral, drug therapy, and psychological therapies, pain relievers, splints, acupuncture. I have been finding some Ayurvedic management more helpful in arthritis, etc., therapeutic massages, and multidisciplinary approaches. Next. There are specific problems for elderly women, which basically involve changes in the body composition, discrepancy in energy production and utilization, homeostatic dysregulation, neurodegeneration. What does happen? This leads to frailty, that means person becomes lean, skin and bone, which might result into anorexia or malnutrition, gait disorders, as you see most women come with a gait as if they are going to fall anytime. There is a disability, comorbidity and disease susceptibility, urinary incontinence, ubiquitous ulcers, sleep disorders, delirium, and cognition impairment. So basically, these are some women-related issues. You need to be watchful and manage based on the condition you see. Next, the other problems under women is hormonal therapy requirement, basically because of the postmenopausal hormonal disassociation. Earlier there was a fear that hormonal therapy might harm elderly people. Now it is proved beyond doubt that there is no risk of any breast cancer. So if they require hormonal therapy, can be done in consultation with the obstetricians. Next, senile pruritus. We already talked of a case which becomes more important among people who are restricted, who are bedridden. You may be called to attend to them. Basically, there is one itching any part of the body, which is called as senile, where there is no rash, and you have to rule out xerosis. Dry skin is a common problem in Indian population, which causes pruritus. Seborrheic dermatitis is again a localized itching and skin manifestation, usually in greasy or oily areas. There could be psychogenic pruritus, and another rare but problematic condition is what is called as nummular eczema, which is nothing but an late onset of idiopathic atopic dermatitis, usually extremely pruritic, inflammatory skin in elderly patients. Next, there is a new concept of monitoring the elderly people's health, which is called as VO2. V stands vitality of oxygen. This is a maximal oximal consumption, which is measured by cardiorespiratory fitness. This has three components. Its lungs capacity and heart volume. The more oxygen your lungs can take, the more oxygenated will be our blood and heart can pump. There is a secondary capillary delivery where the more oxygenated blood your circulatory system can transport to your muscles, the muscles are more active. Muscle efficiency is the third category. So we have given you some of these criteria at different age, what should happen. Ideally, elderly people should try to maintain at least 75th percentile, whereas the others should maintain at 90 percentile. And if you can look at the last age group, at 78%, around 25% of oxygen capacity is good enough to maintain life. This is something new you need to look at and start whether you can practice this to help your senior citizen patients to live comfortably. Next, here the aging also affects our focus. As we already discussed, the brain function, the brain has function of memory processing. Hippocampus and frontal lobes undergo anatomical and neurochemical changes over the time that results into two things. What is that? We will find harder to summon once familiar facts or divide our attention among two or more activities. Therefore, elderly people can focus only one item at a time. Sometimes the hearing loss also causes difficulty for them to distinguish speech in a noisy environment. Therefore, their action might become slow. Most of us start noticing these changes at the ages of 50s and 60s. They can cause what we call as memory and thinking problem. They are basically stemming out of underlying brain disease. It reflects a slower processing speed, poor encoding, and retrieval of new memories. Therefore, you suddenly lose the recent thing what you have done. Old you may remember. Even though that brain is slower to learn and recall new information, their ability to make sense of what already they know or from reasonable argument or old understanding, they can make better judgment. These situations one can help in limiting the problems by improving. These are worsened because of the poor sleep, but structural changes that takes in the elderly brain as they age can explain some of these development. Next, our culture also has a role in multimorbidity. In India, we are fortunate that elderly people live with us. Therefore, socio-demographic issues, financial situation, family condition, age, education, religion, caste, all of them play a role. And as a practitioner, one should look at their background and see how much of that can be helped based on what the community or the family can afford. Next, there is an impact of multimorbidity on long-term outcomes of general surgery because elderly people may need surgery for hernia, prostate, etc. There it is a proved fact that multimorbidity increases their hospital stay, case fatality rate, delayed discharge, use of oxygen, walkers, etc. at home, and a longer hospital stay. This is based on a study done among about 1.75 lakh people up to 3 months after the surgery. My last slide says the gaming can improve the mental health. If elderly people, there is nobody at home, they can use the positive impact of online gaming. It helps in cognitive benefit as players engage in complex problem solving that improves mental agility and critical thinking. Social connections, people can interact with people across the world while they are playing chess or any other game. It also relieves them stress relief when they are alone because of the stress they have. Children are out, nobody is to talk, no neighbors, etc. And it improves their creativity and imagination. But remember, they may also have a negative impact if it becomes too much addiction and compulsive behavior. Socialization, they get involved in the digital or virtual connection so much, they may not even talk to their neighbors. Aggressive behavior, having seen the violent video games, they are desensitized to violence and they increase their aggressive behaviors and thoughts. Impact on eyes and ears for long exposure of loud volumes and screen, we all know, and mental health issues. They exacerbate depression, anxiety, mood disorder. The competitive nature of these games lead to stress and frustration if they start losing. Here, the families need to help set up boundaries, time limits, monitor and encourage monitor what they are seeing, encourage physical activities, foster real life social connection, monitor contents and behavior, protect ears and eyes. My final message, dear friends, is only the general practitioners who is in a better position in developing countries to address the multimorbidity in older adults. I don't know whether it is possible. The government has to revise the general practitioner system both in government and private sector. Then only the multimorbidities can be handled better. I thank the organizers. You warned all despite the delayed version, and we were at least half an hour late in completing the session. Thank you very much. If there are any queries subject to organizers permitting, you are welcome. Thank you, Faisal.
Uh, Yeah, thank you so much, sir. It was a really wonderful and very informative talk. I hope this information will be helping all the participants and doctors who have joined this session, sir. So I can see, sir, there are feedbacks from Dr. Ankita. She has written wonderful talk and well explained. And another feedback is from Dr. Subramanian. He has written well explained. It was wonderful session. There was two feedback, sir. Sir, as I can see, sir,
Okay,
there is no more question, sir. With all your permission, shall we conclude this session for today?
go ahead.
Sir, shall we conclude this session for today?
Please ask them to. You have their my mobile number. They can WhatsApp if they have any
Yes,
queries
sir. If there
on
is any
WhatsApp.
question, you can comment it in future also on this like video, and you can contact sir also. His name is Dr. Suresh Krishna Rao, and he is very informative and he is keen to share all the knowledge with all the doctors. Thank you so much, sir. It was wonderful to have you. Till then, take care of yourself. We will like to see you in future also. Thank you so
Thank you.
much, sir.
Sorry for the interruptions
Take care,
again,
sir.
but
Have a great day. Thank you.
thank you.